what mental health, oh, got it. What mental health court research is out there is positive, and there's getting to be more and more, and it's pretty interesting, some of the things we've been doing, but it does show that there's a reduction in recidivism, which is overall, obviously, what we're looking for. So as we went through these standards, I'm going to just throw this out to you. As I went to prepare this, I thought, what are some of the areas that are a little bit different? So in my mind, responsibility, this definitely isn't an R&R training, but I'm going to talk a little bit about it just because it's so critical to this. So in a mental health court, you'll probably hear me say this multiple times today, but we always think meds, money, and housing in mental health court, because when your people start, those things are unstable for them. They're pretty unstable typically in drug court also, particularly the housing, sometimes the money and the meds also, but in mental health court, that's always an issue, okay? Substance use, I think, is a big issue that's a little bit different in mental health court. We'll talk about it a little later in more detail, but it's much more common, I think, than a lot of people think. If you've been doing it, you'll realize it's pretty common. Like right now, I coordinate 3 adult mental health courts in 3 different areas. And this year so far, I've had 0 participants that don't have a substance use disorder issue. There's been a couple times we've had 1 in a year, but I mean, really for us, it would almost be 100%. There's that occasional person without a substance use disorder. Employment we'll talk about, it's obviously quite a bit different, probably in mental health courts than drug court. Treatment, we're going to talk quite a bit about that. A lot of similarities and some really significant differences. So that we'll tease that out. And then sanctions. So sanctions is another thing that is really pretty similar in some ways, but obviously there's some little differences that and nuances that we'll talk about. So here's where I'm going to throw out, those are kind of some of the things I'm going to address, but if you've got other things that you said, oh, what about this? This is obviously a difference. Throw those out there, put them in the chat. Marie can get them to me and we'll certainly talk about them. But those are kind of the main topics we're going to go through. Okay, so if you're familiar with the drug court standards, so this was volume 1. So we're going to talk about most of these. Those are the areas in volume 1, target population, roles and responsibility of the judge. We're going to tease each of these out. Volume 2 covers these areas. I'm going to talk about each of those also as we go through this. So that's kind of the comparison we made as we went through the drug court standards to see how they apply to mental health court. Okay, I'm just going to throw a couple resources out to you. You may have seen these. So this is 6 steps to improve your drug court outcomes. This really deals with co-occurring disorder, folks. It's a super good fact sheet. If you're familiar with it, great. If you're not, and you're in either a drug or mental health court, there's a lot of good resources in there. What I like about it is it lists out different assessments for substance use disorders or mental health disorders, evidence-based assessments and things that you can use if you're familiar with that.
Hey, Eric.
Yeah. Yes.
Your sound is cutting out just a little bit every once in a while. Would you mind going ahead and just like turning off your video for yourself? And that might help with that a little bit.
That's a great idea.
We'll see.
The only challenge now is if I'm talented enough to do that, Marie.
Well, maybe I can turn it off. Let's see. Stop video.
I think I did it. Yeah. One of us did it.
All right. We'll see how that goes.
Okay. Yeah. Glad you let me know. Hopefully that won't happen. Usually I've been good in this room. So am I good right now anyway?
Yes.
Can you hear me okay? Okay.
Yes.
Okay. So this is the other resource I want to just make you familiar with. These are all the people on the right that put it together. I just refer to this as the Green Book. You're going to see a couple slides with the Green Book on it. Fabulous as far as it's adults with behavioral health needs under correctional supervision. Talks about that risk need responsivity model, several things that way. So this is a fabulous resource. If you're interested in that, if you want to let me or Marie know that it's hard to get the Green Book anymore, but I have a PDF version that's I can email to everyone. Okay, so here's a little recap before we really dig in. In a nutshell, all the standards of drug courts really apply to mental health courts. If we make a few adjustments or adaptations to things, but pretty much they all work. There's a few adjustments we need to make. The risk-need responsivity model is really foundational to both. We found, and there's some really interesting things we'll talk about with mental health court later as it pertains to that risk-need responsivity model. Obviously, co-occurring folks you're going to have in both. I think we're pretty good now knowing that the expectation is going to be, whether you have a drug court or a mental health court, you really have a co-occurring court, and you're going to have to be able to deal with both at each turn, the mental health and the substance use. And then as far as the high risk, high need, the things we're going to talk about today, obviously drug court goes off the high risk, high need model. We do the same in mental health. There's some quadrant type things that some people do with mental health courts and with drug courts actually to deal with some different risk levels and need levels. We won't talk about that much today. We can if there's questions about it, but pretty much what we're comparing right now is the both high risk, high need folks that are in mental health court and drug court. Okay, so if you think about it, if I said, what's the goal in your recovery court, whatever recovery court it is, mental health or drug court, we want people to improve their functioning, right? We want their housing to get better. We want their employment to get better, quality of life. But ultimately, what we're wanting is a reduction in recidivism. Okay, that's common among all recovery courts. So let's talk about how we do that here. So when you think target population, obviously the biggest difference between a mental health court and a drug court is the severity of the mental health disorder. So that's probably the biggest thing as far as when people have co-occurring courts, and they always say, well, how do we know who goes to mental health court or to drug court? So in our area, for example, we have multiple. We have health courts, we have drug courts, we have other co-occurring courts. So really it's delineated by really being specific on our target population as far as who goes where. So in mental health court, you're going to get folks with that more severe diagnosis, schizophrenia, diagnosis, schizoaffective disorder, bipolar disorder. That's not to say you can't take folks with a lesser diagnosis, but ideally a drug court can deal with those folks that have a little less severe mental health disorder. What I would say is make sure you know that, because it is kind of hard in a lot of places like here where we have multiple courts. It isn't uncommon for folks to want to be transferred in between courts. It's really hard, no matter how often, how many assessments you do, and we really push, getting your assessments right up front. It's really hard to get all those assessments correct all the time. If you've ever been the clinician that's trying to figure that out, and you go in and meet with somebody in the jail and you're trying to figure out these symptoms, and they're telling you, I haven't slept in days, and I this and I that, and then, their mind's going really fast, and you ask them if they've used, they'll tell you they haven't used. But, especially around here, meth's really popular around here. So it's really hard to tease out, is someone really having a manic episode, or have they been using meth, but they're not being honest about the meth use. So just give we always say cast a wide net. You want to get those assessments right, but just know for those clinicians that are doing those assessments, it's really hard to get it right. So after about 3 to 4 months of having them in your court, doing drug testing and doing treatment, sometimes things tease out and you go, hey, maybe we do have them in the wrong place. So if there's a way to shift in between courts to make sure they're in the most appropriate place, that's really, really a helpful thing to have in your system. Do not mix participants in different risk levels. So one of the mistakes that I think mental health courts make a lot is people that do mental health courts and drug courts, everybody has a big heart and we want to help everybody. So one of the things that we've seen happen is people say, they don't exactly fit, but we want to help them. We're the only show in town, let's bring them in. If you mix people that have different risk levels or even need levels, you're really not helping them. You're probably at a higher risk of making them worse. I'll just share something that's super interesting about that. All the research shows that, but in Idaho here a few years ago, they actually did a study, it was specific to our mental health courts, and they looked at the risk levels and the outcomes. It actually played out to exactly what national research is for drug court and mental health courts. Those that had the higher risk, we actually had the highest graduation rate with, and the lowest recidivism rate risk. The moderate folks, we did pretty good with them, but we actually had better recidivism rates with the high-risk folks. And the low-risk folks shouldn't be in our programs, right? But about statewide, it wasn't a lot, but there was almost a dozen folks that people had admitted that were low risk. And every one of those participants recidivated in the system. So when we talk about we make them worse if we mix risk levels, that absolutely plays out if we watch it closely. I've talked about risk instruments, making sure you have validated good instruments to address mental health, substance abuse, and risk. We'll talk about all three of those separately here in a bit. And then one of the other big things I think is important when we talk about target population is make sure you have the services available to make the folks that you're screening and assessing into your program successful. So for example, our program has been an ACT model for years. Well, the ACT model is kind of that really hospitalization model that moved out of the state hospitals. So they're folks with real severe and persistent mental illness. So, you know, we got folks with diagnosed with schizophrenia, schizoaffective disorder. And we don't take folks that are more mild in their mental health diagnosis because it's not appropriate treatment for them. Make sure when you're screening folks in that you have the services that are available to them. So if you can't take folks that are that severe in your mental health court, make sure you adjust your target population to that. I'll talk a little bit more about this, I think a little later, but the other thing that's really an issue in mental health courts a lot is what do we do with folks that are diagnosed with a TBI, a traumatic brain injury? Or what about folks that have some developmental disability type issues? So oftentimes we want to, again, have big hearts and we say, let's bring them in. But if we don't have the services available to make them successful, we're really not doing them a favor. We're actually doing more harm to them. So we want to really be aware of that. Okay, census and caseloads. I don't want to talk too much about this one, but I would say one of the bigger differences probably in mental health courts and drug courts is there are a lot of drug courts that have quite a bit bigger caseloads. So as far as in their court, you know, most mental health courts are smaller. There's a few that have quite a few, you know, 30 to 50 or more participants, but most of them don't. A lot of the supervision caseloads are really high for the probation officers. I wish it was better, but I don't know where you're at there in Tennessee, but here we have really high caseloads. A lot of times, at least they are specialized. So folks are specialized in mental health on those supervision caseloads, but those caseloads are really high. But typically the amount of people that you have, your capacity in your mental health courts is a little bit smaller overall than drug courts, which makes sense because the intensity of the need on the mental health end particularly is more intense. So, okay, historically disadvantaged groups. This is really a pretty general standard out of drug courts, which really fits well with mental health courts. We obviously don't want to deny people based on race, ethnicity, gender, anything like that. Here's where the cognitive functioning level does present a challenge in mental health courts. So just a little brief story. I started once, I used to have a diversion mental health court that we targeted low risk individuals for that. What it ended up being, if I'm going to summarize this story quickly, is a lot of folks that had developmental disabilities, you know, cognitive challenges that were actually in group homes, and the group homes didn't know how to manage them well. So whenever they hit anybody at all, they'd call the police, and it ended up really being us guiding those facilities on how to handle those folks better. So you'll get a lot of, at least we do, you get a lot of people that are even dually diagnosed with maybe a developmental disability and that their IQ is right on that range, you know, right around the 70, but they also have an co-occurring mental health disorder. So you really need to decide if your program has the ability to take those folks in and be successful with them. We set a limit on ours so that we're not taking them in below, you know, if they just have a developmental disability. But even those right on the edge, you want to make sure that you can really be specific with your programming, that you can customize things to them. You might need to do some more things if you're doing, you know, the evidence-based treatments, and a lot of it is the, you know, cognitive behavioral stuff. Some of them might not be able to do that. So if you can break things down and make it more simple for them, that may work. If not, you're really not helping them by having them in your program. The other thing to really watch with them is risk level. Make sure you're not putting some people in there that might be victimized or taken advantage of by some of your more higher functioning criminal thinking folks, even in a mental health court, because there is quite a functional range that's different there in your mental health court for you to be aware of. Okay, roles and responsibilities of the judge. So all these standards apply to mental health court. If you read through there, the couple things that would be different is obviously there needs to be some specific mental health disorder training for your judges. If you can get them to trainings about mental health, that's fabulous. Co-occurring mental health disorders, obviously they need that training. We'll talk more. I think that's super important for judges in mental health courts. And we'll talk more why when we get to the substance abuse portion, but substance use disorder portion. But you need to have that training. You need to expose them to as much training as you can. They obviously don't need to be experts in it, but they need to understand it a little bit. I think a big way to do this, honestly, besides sending them to trainings, is just doing training within your team. So we have, I'm sure you guys do too, we have what we call quarterly meetings. They happen to fall on our 5th week of the month because everything in our program is set up on 4 weeks. So every time we have a 5th Thursday in our program, we do a little training. So that training can happen for your judge and for the rest of your team, even within your team, if you'll do it. Maybe have the mental health folks talk about, what treatment really looks like. What does MRTs look like, DBT, and they can explain that and that really helps your judge understand that. So when they're on the bench and they say, hey, we're talking about MRT step 3 or step 1, whatever it is, the judge knows that that's about honesty, or that's about following rules, and what that is. That can really help them hold them accountable. It lets them know that the judge is involved and really understands what's going on. It's fabulous. So the last part I want to talk about in this is the 3-minute rule. So I'm assuming you all know the 3-minute rule. So if you don't, I'll kind of recap it for you quickly. So one of the things that research has shown that is if the judge will spend at least 3 minutes with each individual in your court, the outcomes go up dramatically. You get way better outcomes. So here's what I would say about this as we've seen it in mental health courts. This would apply to drug court too, but particularly to mental health court. 3 minutes is awesome. 3 to 5 minutes is fabulous. We have seen sometimes where we get really in depth and really involved here, and we think, well, if 3 minutes is good, 10 minutes must be fabulous. In my personal opinion, the research says the 3-minute rule, as I explained it to you, that's what the research says. In my experience, 10 minutes does not necessarily make it better. So judges, really be aware what you really want to accomplish in that 3 to 5 minutes is that individual, feels like you care, that there's a relationship there, that they say, hey, he or she really understands or wants to know what's going on in my life. You're gonna hold them accountable, but make sure you stay in your role. Just because 3 minutes is good doesn't mean if you slip into counseling and finding out too much information, a lot of times that gets us into a little bit of trouble, particularly in mental health court. They may go on a tangent. Sometimes they may become even more symptomatic about things if they're not super stable. So as treatment folks, you can also help your judges say, really be aware of this, or really be aware, so-and-so really gets fixated on this, kind of avoid that. Or if they bring that up, here's the best way to deal with that. So really be aware and help your judge with that 3-minute rule. I think it's fabulous, but it really does need to be monitored a little bit. Here's the other part of that I think is super important. The 3 to 5 minute rule, also the way we violate that tends to be when we focus on people with problems. So typically what we'll do is someone that has problems or sanctions or issues we need to deal with, it's easier to take 7 minutes or let that get a lot longer because we're dealing with issues. Whereas the person that's doing really well, we take 1 minute and say, hey, good job, you're doing great, we'll see you next time. When really what we want to do is spread that out. Even that person that's doing well, we really want to focus on those positive things. The more we can share the positives, really praise them for that, clap for them, whatever we'll talk about more that you can do as incentives, but really focus on those that are doing well. So you don't just spend a majority of your time on people with problems. So that's about all I'd like to say on that at this point, but super important. The 3-minute rule applies to both. Okay, other services. So one of the things we'll talk about here, complementary treatment services. The responsibilities piece starts in 1. We'll talk a lot more about that. Trauma, obviously, I'm sure you've talked a ton about trauma. I think we've done a pretty good job of getting trauma out front and center. So I'm not going to say too much other than I think whether it's a drug court or a mental health court, you're going to have a plan to address and deal with the trauma issues. Criminal thinking. One of the things I think super important for these mental health courts, especially when you're dealing with high risk, high need folks, is that you address that criminal thinking. I'll talk quite a bit about that because there's some specific research that I think is super important about that. That was something that's actually evolved through the research. When we actually started these mental health courts 20 years ago, there were a lot of mental health courts that did absolutely nothing about the criminal thinking. And many of you probably remember Judge Goss. I think Marie said he used to come to Tennessee as well. Used to do a lot of training with Judge Goss. And it was so funny because we talk about this criminal thinking piece a lot. And we've been doing it a while. And his recap was always this. He said, so if I'm understanding you right, if I have one of these folks that's high risk, high need in my mental health court, and I bring them in and we get them, so they're not using substances anymore, and we get their mental health, disorder stabilized, but we don't address the criminal thinking, then what we've got is a clear thinking, sober criminal. And that's kind of true. I liked his recap of that. If you don't address those criminal thinking components, you might have made parts of their, we're not going to reduce our recidivism. We'll talk a little bit more about that. Okay, so let's talk about vocational and educational requirements for a minute. That's one of the requirements that definitely is different in drug courts. Most drug courts require people to be working full-time or mostly full-time. In a mental health court, you're going to have people that are on benefits, some of them aren't, so some of them are more motivated to work. Really, the motivation to work is so interesting with this group because a lot of them don't have, some of them really do. We see sometimes the same thing you see in drug court. They want to get working, they get working, and working becomes their focus rather than treatment. We have others that, there is no way it's going to take more than an act of Congress to get these guys working. They just won't. But if they have benefits, I think what's important is realizing what's the need. So if they have benefits and they can actually manage that money, or if they need a payee to manage that money and they can sustain themselves on that, then I think that's great. If not, they may need some work that may be something that they're going to have to be able to, provide for themselves and be able to function. The other thing is sometimes you just want them busy. That's similar in a drug court or a mental health court. A lot of them need something to do. So maybe even some part-time work or things like that are beneficial to them. But realize just setting that expectation of you're going to have to work 30 to 40 hours for all of them isn't really going to work in a mental health court. However, that's another thing you're probably going to have to really individualize, because for some of them, part-time work, at least some of them full-time work is fabulous for them. So that's something your team has to tease out. And it's something that when we talk about incentive sanctions and therapeutic adjustments, it's important that you're judging your team when you address that, really explain that well, because the first thing they do is say, well, why are they requiring that of me, but they're not requiring that of Marie? That they will constantly do that. They compare their situation with other people. So really be aware of that. As far as assessing and addressing physical health issues, that's a responsivity issue I'm going to talk a little bit more about in a minute, but the physical health issues are complicated in both drug courts and mental health courts. I think they're even more complicated probably in mental health courts. We've had a couple people that started, we had a guy start not long ago that when he started, he was sitting in the back of the courtroom and literally you could hear this poor guy breathing throughout the whole courtroom. Something was going on in his nose with his nasal cavity. He could not breathe. So if he really can't breathe, he happened to be rooming in the transition house with somebody else in our program. Well, after he'd been in the program about 3 days, neither one of them was doing any good, because even now our person that was rooming with him couldn't sleep. So there's a lot of physical things that go on with these folks. Simple things like even getting in for glasses, maybe hearing aids. We've had a ton of that lately. Just realize if we've got to deal with those kind of physical and issues so that they can gain the skills that we want them to in our cognitive behavioral groups. So really be aware of that. Similar in drug court, but probably more pronounced even in our mental health court population. Okay, multidisciplinary team, super similar. You're going to have all the basic people. Who else do you need probably in mental health courts? I know now, I don't know if you have those in Tennessee. I believe you probably do, but peer support specialists and/or recovery coaches are a key component here now. So we've got a couple peer support specialists on our team. One that comes to court, that's fabulous. NAMI, is probably somebody you're going to want involved in your mental health court that you probably don't have in your drug court. So any advocates and folks like that. I'll give you just an interesting one that we came up with that we didn't think we need, and we don't have them there all the time, but it is important, is we've had several people that when they have started working a little bit, they have so many garnishments from child support and different things. So we've actually brought, at least made a contact with a child support representative, so that sometimes we need to do some adjusting and things with those orders. We've had people that we couldn't figure out, but they just quit work after so long. And it was because child support would catch up with them and take so much of their check, and they really didn't have the skills to advocate or figure that out. So they just quit their job and go get another one. So just things to think about. If you're having an issue, it might be worth inviting somebody in to deal with that issue onto your team. As far as court staffing and hearings, those are really similar. Sharing information, all the same things apply. Judge, all the things really on this, other than you might need a few other people on your mental health court team, are really going to be similar between your mental health court and your drug court. Okay, so let's talk treatment for a minute. So individualized, it's not just about the medication. That's so true and so complicated at the same time, because it's not just about medication, but medication in mental health court is a huge piece of the puzzle, especially right at the beginning. So I'm going to talk a little more about that, so I won't say too much. Co-occurring disorders require the integrated treatment. We can talk more. I'm super excited that I'm getting to come out to Tennessee here in about 10 days or so. So we'll have some more information on this. But I think what's important about this is make sure you have the integrated treatment. When we started, we just dealt with mental health. And I think a lot of times, I think we're past this now, but a lot of people thought in a mental health court, if we could just get people would say this, we'd hear this all the time. Excuse me. They'd say if the mental health system would just do its job, we really wouldn't need mental health courts. So having started working at an ACT team, I totally don't believe that to be true, because for the low risk folks, that's probably true. The mental health system can really manage them. Our folks that have these co-occurring and high risk, the high risk folks really need more accountability from the probation departments and from the judge. They really benefit from that. So we really got to manage that. Continuum of substance use disorder. We'll talk about that continuum more in a minute. Be intentional with your responses. I think this is super important. I think a lot of times when we get going in these courts, it's really easy, particularly in mental health court, also in drug court. There's so many what the clients would consider crises going on in their life, that it's really easy to be chasing your tail, like a dog chasing its tail. It's like it's always something else. It was something yesterday, it's something today, and they're really similar, but they're always in crisis. Part of that is the skills that we want to build with them, so they're not always in crisis. So we want to be really intentional about what we're focusing on and help them, because we all want to be focused on the same team, on the same things. And it's pretty easy for mental health or substance abuse to be focused on something different. They talk about something else when their probation check in, but the judge is really going to ask me something else. If we can really centralize that and all focus on a few basic things with them, it really helps them to stay focused and build skills. The central 8 need areas, I haven't said that yet in this presentation, but I'm going to talk more about the central 8 risk and need areas in a little bit. So I'll just kind of tab that one. And then recovery support. You've probably seen, I saw some nods of the head, the recovery coaches and the peer supports really fill a slot that we didn't have before. They are fabulous. And you've probably seen this, but what's really, in my mind, hopeful and a positive thing is we've had graduates of our program that have moved into those slots. And man, when you talk about their overall recovery, because we talk about what does recovery look like for people, and it's individualized, but when they graduate these programs and then they can actually get employment, get training and employment and be working in this field, it's just phenomenal for them. It's just so great to see that. So that's a really big piece to the puzzle. I'm just going to throw this out. These are just evidence-based practices kind of things for mental health courts. There are also some things that will help in drug court, but in my mind, the more evidence-based pieces you can put in place for your mental health court, the better chance you have at success long-term. So you probably have each of those in there. It's just an interesting slide to make sure you're looking at those things. Okay, so I told you I'm not going to spend a lot of time on risk, need, and responsivity, but I do want to spend a little bit of time on responsivity, particularly here for a second, because it's so important in mental health court. So I'm starting at the end of the RNR here, the last R, but when I think of responsivity in my mind, I think of everything that keeps the person, the individual in our program, from learning the skills that we're trying to teach them. Okay, so when you have someone come, particularly in mental health court, I think of these things. Again, here's your meds, money, and housing. So when they start and they aren't stable on their meds, that's going to be an issue. They're not going to do well in group. They're not going to be able to learn, whether it be MRT, DBT, whatever skill we're trying to teach them, if they're unstable. So it's important that we get the meds part. Money and housing, meds, money, and housing. I think of that as kind of like the Maslow triangle. You all know Maslow's deal, where those basic needs are along the bottom. Even if their meds are stable, if they don't know where they're going to eat or where they're going to sleep that night, none of us would focus in group either if we didn't know where that was. So it's important, particularly in mental health court, to help them stabilize those meds, money, and housing, because it's really hard. A lot of times their money's usually sometimes shut off because of jail. Housing is really similar to drug court, even more so because typically they burn out those relationships with family members. So the only person they got to stay with is their, great friend that they got charges with, or there's a domestic issue, the scenario. So that part's really hard. We really want to focus on that. Be aware on the right side of this slide. Again, we talked a little bit about the cognitive issues. If somebody's really not getting it, we need to figure out why. Maybe it is something cognitive. Maybe it is they can't hear. Like I said, we'd had some really several clients that we've got hearing aids lately, and we're like, what's going on? Why can't they retain information? We kind of thought it was a cognitive issue, and it turned out they just couldn't hear very well. So they weren't really able to gather what's happening in group. Cultural issues, obviously important. Be very aware of those. If those are issues, make sure you can make some adaptations to that. Medical issues, I've already talked a little bit about that. There's other things you can think of. My big piece with responsivity is, you're going to hear me say in a minute, is their behavior non-compliant behavior, or is it non-responsive behavior? Okay. Non-compliant is pretty easy. They just don't want to do it. Non-responsive is they're not getting it. They can't do it. They don't have the ability right now to do it. So anytime it's non-responsive, go back to these responsivity factors. Is there something that that we need to adapt to? That I always think of responsive is on us to make adaptations to our program. What do we need to adapt so that they can be successful and gain the skills that we're trying to get them to gain? The last thing on this, it really doesn't pertain completely to this, but I want to talk about it a minute, is meds. So when we talk about meds, it's so important at the beginning, but particularly in mental health court, mid-program and follow-up meds are super important. So what you'll see with this in mental health courts typically is, once you get them stabilized, it's really common what happens. If we were live, you'd all tell me this, right? They start saying, everything's going great, I don't need the meds, right? You've heard them say that. So you really want to focus and have a plan for that. We love it when they'll actually tell us that and be honest about that. When you start talking long-term, a lot of times they will say to us, I don't plan on taking meds beyond the program. That's super important for us to learn, because if they're not, that's probably not going to end well, right? For them or for us. It's probably going to end in a high chance of recidivism. So we like them to tell us if their plan is to go off, we want them to try to work that out with their prescriber while we've got them. Okay, while we've got them in our program. I always think of like the bowling alley with the blown up little tubes in the side. We want them to experiment while we've still got them, and they can't roll a gutter ball and just recidivate and get back in the system. So those are some of the key, probably more important responsivity factors to be thinking about. This is just we always say in our program, you'll hear welcoming, empathic, and hopeful. A lot of these folks have failed multiple times, many times over. So we want to focus on recovery, obviously, focus on their strengths, and then we want to be hopeful. That's really easy the first couple times you meet with them. Once the criminal thinking parts kick in, that becomes a little bit more challenging. But you can remind your team, they failed multiple times. How are we going to get them to complete this and focused on recovery? Okay, so I want to talk a little bit about risk here for a minute. So when we say risk, I'm sure you're familiar with this model. What we're talking about is matching the intensity of the interventions to the folks, to the individual. So this is really a drug and a mental health court thing. And then when we talk needs, they have a ton of needs, okay? Antisocial needs, you're going to see that in mental health court and drug court. And we want to build skills in those areas. So I don't want to spend a lot of time on the R&R model, but I do want to spend time on the central 8, and this will lead to that. So this is some super important, I think, research done by the University at California, Irvine. Dr. Scheme actually did this research. And so I want to focus on a few of these. SPMI offenders are double the risk of failing supervision. Why do you think that is? It ties into the second one, right? They're more likely than others to fail because of technical violations. So they're more likely, without us intervening and teaching them skills, they're probably going to show up late. They may miss some probation appointments. They violate for a lot of different reasons. So if every time they showed up a little late or missed an appointment or something, they were violated, it makes sense that they'd be at much higher risk for failing supervision, right? Here's the, in my mind, the next two are probably the biggest keys. So the third bullet, the strongest risk factors for recidivism are shared by those with and without mental illness. Okay, so let me read that again. The strongest risk factors for recidivism are shared by those with and without mental illness. So that applies actually to our drug courts and our mental health courts, but most people don't think about that. They think about mental illness, especially in a mental health court, being a risk factor, okay, for recidivism. It's really not, okay? It's the central 8 that we're going to talk about. So the next bullet, risk reduction is not based on receiving more mental health services. So we can get them a ton of mental health services, and that helps. If we get things stabilized, that's important, but that's not going to lower their risk per se to get back in the system. Is it going to stabilize their mental health? Absolutely. But there's some other things that we really need to focus on if we're going to reduce recidivism. Do we want their symptoms to be decreased? Absolutely. Do we want housing to be better? Absolutely. We want their quality of life to be better. But if we don't focus on some other things, we won't keep them out of the system. Relationship quality is important. So we've talked about that. I'm sure you're good at MI, building relationships. This needs to come from all members of your team, probation, treatment, the judge. Everybody needs to just be aware of that, how important that relationship is. And then a problem-solving approach, avoiding negative pressures. So I call it the 1970s probation, where why do I need to do this? Well, you need to do it because I'm the probation officer and I said so. Obviously, we know that's not going to work, right? So we need more of a relationship, problem-solving approach if we're going to keep them from recidivating. So here's what's interesting. So here's the central 8 risk factors I'm referring to. You've probably seen these, but what's interesting is if you look on this list on the left and say, what's the risk factor? Okay, you probably see a pattern in the first 4, right? Antisocial, 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 antisocial. What's interesting is family's probably not surprising, work's not surprising, recreation's not surprising, and substance use isn't surprising. What is surprising is this is for mental health court as well. If you look on there, do you see medications on there? You see mental illness on there? Nope. Do you see money on there? Not really, right? Housing isn't on there either. So what's interesting is those responsivity factors that we really want to be aware of, meds, money, and housing, they're super important that they be in place. They're actually not recidivism factors. They're super important factors to stabilize the mental health so that they can build skills in these areas. But where they actually stay out of the system and build the skills to stay out of the system is dealing with these issues on the left, the antisocial pieces, those big 4. And then a lot of it, and if you've done this for a while, I'll say this about drug courts and mental health courts, having worked with both. I think drug courts, and for the most part, mental health courts, do a really, really good job of getting people sober. Okay, they really do a good job of helping them get into treatment and reducing the drug use and actually getting them abstinent. I think they do a really good job. We do a really good job on that part. But I think what we need to realize, if we've done this for any amount of time, is the substance abuse is a risk factor, but honestly, it's a lot of these other pieces. It's almost always, in my experience, relationships and the people that they're hanging out with. That's what leads them back into the system. Some of it is quote unquote friends. A lot of it is relationships, either past or present. They have an ex that they have kids with, whoever it is, it's almost always tied into relationships. And these antisocial people that they're hanging out with, the way they think, that's how they think as well. Okay, so that's where we've really got to focus our energy. Love this slide. So what this says is every time they address, going to the left, every time they address one of those risk areas, that's how much greater outcomes they have. To the right, what's interesting is those 3 areas below the line. If all you do is focus on the mental health, those folks actually get worse and actually get poor outcomes and recidivate. So we really want to focus on helping them gain skills in those central 8 risk areas to be successful. Okay, so I'm going to switch to substance abuse treatment here, this co-occurring for a minute. So one of the things that's important is having the right assessment tools in place. So for one, your mental health, you want to get the right folks in there that you have services to help them be successful. Risk assessment, you obviously want people that are on the moderate to high end of risk so that you're not mixing and making people worse. Substance use disorder, to me, this is one of the biggest challenges you're going to face in mental health court versus drug court. And this is why. So let me skip forward here a minute. Drug testing, we're going to talk about. You've got to have drug testing, partly because it's so hard to tell with these folks. They're all co-occurring and those symptoms mimic each other. You know, like we said, meth use before versus mania, they mimic each other. And we all know this, they lie. So you can't just trust them and say, oh, they're not using. You've got to know what's going on in there. And it really helps your treatment and your prescriber to know, okay, they're using, they're not using, these symptoms are present. And if they're not using, this really is a mental health piece that we need to address. Okay, so as we talk about mild versus moderate substance use disorders together, that's where I think the big challenge is in mental health court. I got one more slide, then I'm going to talk a lot about it. So your drug testing as far as court versus mental health court, honestly should be the same. Okay, we need the same piece in place. It's got to be frequent, random, observed, at least 2 a week, within 24 hours, all that should be the same. Here's what I would say. If you do have folks, we've had a few that actually don't have a substance use disorder issue. They don't use. You obviously don't want them in your testing. So don't do it just for fun if they actually don't have that issue. But it's probably a rarity. And if you're not sure, I always say, if you're not sure if they have it, test them for a little bit. If you test them for a couple of months and you thought there might not be any and they haven't had any positive tests, then you probably need to pull that. Don't do it on people that don't have substance use disorder issues, but that's probably rare in your mental health court. Okay, I want to take a little bit of time on this slide because this is, I think, where one of your biggest challenges comes. The challenge in this is when in a drug court, they screen people into drug court who used to be what we'd call dependent. Now we call them severe use, right? Moderate to severe users. So people that are using regularly that would be on the end of being addicted, right? So that's everybody that you screen into drug court. The challenge you have in mental health court is you're going to have people all along this spectrum. So you're going to have some people that are severe users, you're going to have some that are moderate, and you're going to have some that are mild. Okay. The challenge is in a mental health court, you want to respond differently. There's different evidence-based responses for those folks. Okay. So let's talk about it. So the second bullet would be your drug court people. So if they really are severe on that scale, then having sobriety, being sober is a distal goal, right? That's probably not going to happen for 6-8 months or so down the road. Okay. If they're mild users, okay, sobriety is a proximal goal, meaning they need to be sober like right now. We need to expect 0 use at this point. The challenge in mental health court is you're going to have some of those people that are mild, that are expected to have no use, and they should be sober right now, abstinent right now, and others who are going to be on the distal scale. That's challenging to your team and your judge because you're going to give different responses in court, right? So it's really interesting. I'm going to pick on Marie and Rebecca because they're the 2 people I can see on my screen. That's why. So if I come in and the judge sits down and 2 people just started and Rebecca's on the severe end, right? And Marie's on the mild end, but they just used, and I'm going to do this briefly, but if the judge says, okay, Rebecca, you're on the severe, he's probably not going to say that, but you're on the severe end. So we're going to give you 1 day in jail. Okay, Marie, we're going to give you 4 days in jail for the same use. Okay, you can see how that's going to go across to your participants. Because Marie just used because she thought, it's Friday, I'm going to go use with my buddies. She's not really addicted or anything. She's not really craving, but she knows that, that 1 day they're going to give me in jail because that's what they do with everybody is totally worth it to me. Whereas Rebecca, she is having cravings, she can't stop using, one day, if any, is probably going to be plenty or too much for her. So we can talk a lot more. We've got a whole session coming up, when we have the training that we'll talk about incentive sanctions and therapeutic adjustments. But this is one that I really want you to be aware of briefly as far as mental health courts and drug courts and the difference, because it's one of the biggest challenges that you probably have. So jail, I do think the part's similar. When you talk about drug court, we expect honesty up front. So we really do want them to be honest and to show up. Honesty, I think you'll hear people say, oh, can they really do that? I think they can do that. The showing up is even a little more complicated in mental health court, though. A lot of them have even less transportation options than people in drug court do. So really make sure when you, at the beginning, especially if you're going to sanction them for not showing up, whatever you're going to do, make sure they really have the ability to show up, okay? Or at least problem solve that a little bit before you jump the gun. One of the worst things that we can do as far as building trust and building that relationship is when we move to sanctions, which would be right for non-compliance, instead of problem solving, which is what we would do for non-responsive, okay? So we really want to know if the behavior is non-compliant or non-responsive. Just to give you kind of a quick how difficult that can be. If someone in mental health court, let's say they don't show up for group on, tomorrow morning, why might they not show up? Okay, this is a lot funner live because you can give me options, but I'm doing it anyway. So they might not show up because they don't want to show up, right? It's like, heck with you guys, I don't want to show up. Could it be that they had transportation lined up and the transportation didn't show up? Absolutely. Could it be that they haven't been taking meds and they finally took their first dose of Seroquel and it knocked them out and they slept through their alarm? Okay, could it be that? Absolutely. Could they use that as an excuse even though it didn't happen? Absolutely. I don't want to go through them all, but I want you to understand it's really challenging at first to figure out, is it non-compliant or non-responsive behavior? So at first, make sure you're erring on the side of non-responsive. What adjustments do we need to make? Could they really be there? Can we really hold them accountable? Now, what's challenging with this group is this. Oh, wanted it to be this next slide that it wasn't. Oh, well, I'll get there. What's challenging with this group is they've got all three components. They've got criminal thinking, substance abuse, and mental health. So don't get caught up in, oh, just because they've got a mental health disorder, they can't manipulate me. They'll do a fabulous job of that, particularly if you think that. So as we talk about incentive sanctions and therapeutic adjustments, again, I've talked a lot about non-responsive and non-compliant. So make sure you know, and if it's a non-responsive issue, that's on us to make adjustments. If it's non-compliant, that's on them. Okay, jail sanctions, I'm sure you're aware of this, but you're going to need to use jail. A lot of programs, oh, we've never used jail. If you're dealing with a high-risk, high-needs population, there's times when you're going to have to use jail. Okay, so make sure you've got meds and stuff set up coordinating with your jail, because it's super difficult if when they go into jail, they're not going to get the meds they're on. If the formulary at the jail is different than the meds that they're on, that's not going to work either. So you're not going to get a good outcome if you do need to sanction somebody, put them in jail, and they come out unstable because they didn't get their meds or they were on different meds. So there's some problem solving that you got to do there. So be aware of that. Matching the incentives and sanctions to the phase, the proximal and distal goals. This is when I talked about those intentional responses. You're going to want to respond. This is similar in drug court or mental health court, differently depending on what phase they're in and what skills you're working on and what the expectation is. Really be intentional about that as a mental health court team to know, what you're incentivizing, what you're sanctioning, and what the expectation is. All right, I was one slide off. This was the slide I kind of wanted right after that. So you can see he who is good with a hammer thinks everything is a nail. Be careful in mental health court. It's really easy to get caught up in, the same responses. So always try to figure out in your staffing what's driving the process. Back to the missing the med group. Are they missing because of non-compliance issues or non-responsive issues? Another way of looking at it, is it willful disobedience or is it incompetence? Because we can help them build skills, but we need to know if that's what we're doing. So that's where it's going to come in. Do we need to sanction? Do we need to incentivize? Or do we really need to just adjust treatment? Okay. Make sure when you do therapeutic adjustments that those aren't sanctions. Okay. So if you say to them, okay, they aren't learning this skill, they've really got, so in our program, it would be really common. They're really having relationship issues. Okay. They have contacts. They don't know how to work with them. and we need them to build skills. So we want to add an untangling relationships group. Make sure that untangling relationships group that you add is a therapeutic adjustment to help them build skills, not a sanction for the behavior. If you want to do something else as a sanction, you can do that. You can do a combination of, we're going to sanction you for this, but we're going to add this group. This is just part of your treatment. You can do an incentive and a therapeutic adjustment, or a sanction and a therapeutic adjustment. Just make sure you're being clear with them so that they don't think your adjustments, are sanctions for them. You never want your treatment to be a sanction. And I think this is probably the biggest thing, is just that figuring out in a mental health court, it's more complicated of what's driving that process. Make sure as a team, you're on the same page with that. There'll be times when you disagree. There'll be times when you sit around the table and Marie says, there is no way, they are totally doing this on purpose. And Rebecca's going to say, no, I don't know. If you don't know, keep teasing it out a little bit. Don't never respond, but tease it out to where you're really confident that you're addressing in the right behavior intentionally. Okay, effective case planning. This goes back to what I said initially of, they have a lot of things going on in there. So focus on those responsivity issues with them first. Okay, get the meds, money, and housing, those pieces stabilized. Then you're going to want to start looking at those central 8 risk factors. I'll be honest with you, most of the time, aside from the antisocial stuff, which we're going to talk about next, it's the relationship pieces. So really be focused on that. If you've got different pieces you can use in treatment to address that, start addressing it. But be intentional with it and be simple for them. If you give them too many things to think about, they won't know what you're focused on. Make sure you're all focused on 1 or 2 things that you're trying to get them accomplished, particularly in mental health court. Okay, I really love this slide. So I don't like to read slides, but I'm going to read this. And so this is page 3 of that green book I mentioned to you earlier. Researchers have identified the central 8 dynamic risk factors that place a person at risk for future criminal behavior. Have found that the first big 4 must be effectively addressed before a focus on the remaining factors will show positive outcomes. Now, here's a quiz I could do with you live, but it's hard to do over Zoom. What are the big 4? What do they have in common? Antisocial, right? So remember, if you've got to focus, think back at this slide. We've got to focus on those big 4 before the other things can be effectively addressed and show positive outcomes. So this is why it's really important, even in mental health court, that you have some cognitive behavioral criminal component thing in there. Whether it's MRT, reasoning, rehabilitation, whatever you use, you've got to address that piece. Because if that piece doesn't get addressed, doesn't matter. Again, it's kind of back to the Judge Goss theory. You can get them stable on their meds, you get them sober, but if you don't address this piece, they're not going to stay out of the system. I found this to be so true. And really, it's tied a lot to their relationships. Okay, so this piece and the relationships go hand in hand. Because who are the people they're hanging out with? Other people that share these big 4, right? So you got to really be aware of that. Okay, I talked about that. Now, I did this on purpose. I do this sometimes. People think, why does you keep putting that slide in there? In my mind, this is probably your most important slide. We have a poster of this in our staffing room. So remember, these are the areas that you want to help them build skills with. That will be true for drug court for sure, but in mental health court, I think it's even more important if possible, because a lot of people think once they're stable, we're fine, but really we're not. We've got to remember the slide. Every time they knock one of these areas out, they have better outcomes. What I really like about this is there's not really an order other than you want to focus on those big 4 from the beginning. Part of the reason for that is they don't change that criminal thinking, that risky thinking overnight. It takes a lot of time to do that, okay? But if they start working a little bit, or they resolve and improve a relationship with a family member, every time they do something like that, their chance for success goes up. So that's super important to be focused on that piece. Okay, this is just a slide to show when I say be intentional, I want you to think about what needs they have. So for example, we have all these options on the table. So if it's really an issue where they need relationships, we'll do an untangling relationships group, okay? A lot of our folks have trauma, most all of them, so they'll go through a TREM group, a trauma group, okay? A lot of them go through DBT. We have some that you get them in there and they cannot tell the truth. If they tripped over it 14 times, they can't tell the truth. So we will put them through Thinking for Good, which is a specific, it's an MRT break-off book that specifically works on being honest, okay? We had another guy last week, he just couldn't stay. He would get sober, and then he would do it for about 6 weeks, and then the same things had tripping him up. So there was another little break off called stay and quit. So we put him through that. So I guess when I say be intentional, just be aware that each one of them has a group of needs that are pretty similar. But when you get looking really at them as an individual, they have individual needs. Make sure your treatment adapts and is intentional to address those specific areas with them. Phase up meetings. I love this. We don't need to talk a ton about this, but we do phase up with our meetings as our phase up meetings with our folks as a way to tie all this together. Okay. So we actually will review their risk assessment at these phase ups. The risk assessment ties perfectly in with those central 8. And we can say, what are we missing? You know, especially with our folks, as you're trying to focus on relationships and things, the housing really drags on. It used to be, I don't know how it is in Tennessee, but since we did the COVID thing, housing has become, it went from like a big problem to an enormous problem here, because now it seems to be even less available and more expensive than it was before. So we could almost always help our folks wrap up their housing in phase 3. We've got 2 people in phase 5 ready to graduate. The last thing we need to do with them is help them solidify housing. So if you do these little phase up meetings with them, it really helps you make sure you've got all the I's dotted and the T's crossed, so to speak, before you kick them loose out of your program. Okay, so here's my little summary. So as we compare drug courts, mental health courts, we didn't find any of those drug court standards that don't apply. All of them apply with a few little adjustments. The mental health court guidelines aren't, you don't have as much research, but all the research we know says, hey, it works. I saw a super interesting research article just recently that was new. So we've done this RNR stuff for a lot of years now. It actually tied it in even more so, saying we really have got to use that RNR model, particularly with mental health court. It was new research within the last couple of years saying that. It even said, I didn't quite understand it. I need to read it. I've read it twice. I need to read it again, but it almost considered the criminal piece a responsivity factor for mental health. So long story short, they're really integrated here, particularly with this high risk, high need population. The model really works. Okay. That is kind of the presentation. So I want to see is there any questions that anybody has about anything
we have 2, Eric. Let me scroll back. So Trish asked a question a little early on. If the court has separate tracks but refers out to treatment, how do we ensure that those agencies look at risk level rather than other factors they may identify, like the level of care needed for A&D issues, gender specific groups, etc.?
That is a fabulous question. So the only way I know of to do that is it takes a little bit of work and outreach on your part. So I would do specific trainings with them. Maybe you have to do a little where you go over there. Obviously, the more you talk about it with them, maybe in the MOU, it's an expectation, but I'll be honest with you, you're about going to have to go over there a little bit and do training with them, maybe observe it a little bit, make sure it's a focus of what they're doing. I'll give you a super interesting example. So we've had this ACT model for 20 years now. It's been fabulous. Just recently, the state decided to yank that out from under us. So I'm having to reinvent the wheel a little bit, so to speak. So I'm actually taking in one of my courts, I've taken my drug court treatment team, and I'm actually training them to do my mental health court treatment. And what was so interesting to me, we just sat through this, what we just covered, right? How drug and mental health courts are similar. When I first sat down with them and said, here's kind of my expectations. And I said, what's RNR? I figured everybody could do a snooze fest. They could do RNR in their sleep. None of my 3 treatment people that were over there had heard of RNR. Like, knocked me off my chair. So don't assume they know just because you know and it's something that you guys are focusing on. Make sure. It might take a lot of reach out with different providers especially, and learn what they're doing. You know, you can say, okay, that's great. Let's see what you're doing. Let's see how this applies. But I think it's important that they do a lot of things. Like, what was interesting to me is they said, what treatment groups do you want? They didn't offer hardly any of what we wanted. I said, what have you got? They really didn't have a lot of evidence-based stuff. Yet they're providing our drug court treatment, which I've kind of been out of the loop. Obviously, now I'm right in the middle of the loop on. So just learn, but make sure you don't just take I don't want to say this, I don't want that to sound wrong. Don't just trust them, but don't just trust them. trust but verify, you know what I mean? So the right things are happening. Otherwise, you know how it is. You've probably done these trainings. And if I say to everybody, who do you focus on? High risk, high need. A lot of people know to say high risk, high need. They don't know what that means actually and how to apply those central 8 so it really works. I hope that, I don't know if that helped. If it didn't, ask me another question, but I probably took that a little too far.
I think that was good. We have another question in chat. Participants who are prescribed mental health meds, should the court make a requirement to take the meds?
Great question. Yeah, you can make it a requirement. Does that mean they're going to do it? So this is a super tricky part in mental health court. So here's how we've figured out to approach it that works for us. You have participants that are not going to want to take meds, right? It's pretty common. I could give you a million examples. I'm sure you could too. Here's how it works though. What we will typically say to them, especially when they start, is we want you to show up and be where you're supposed to be and participate. And when they're not, okay, we try to figure out, okay, you're not showing up. How come you're not showing up? And if we think it's really tied to meds, we'll say, look, we need to get you into the doctor to get you on meds. They'll say, I really don't want to do that. Then we'll say, okay, it's a requirement in this court that you're showing up and you're participating. So if you can do that on your own, awesome. If not, we're going to take the next step, and meds is probably going to be the next step. You know what I mean? So we'll try to incrementally do that so we keep a relationship with them. Ultimately, we'll say, if we have to, we'll say, you're going to need to meet with the doctor. Here's the next step that we found helpful. Because you get in this pickle in mental health court, right? The judge can't prescribe, right? But you want your judge to back the doctor. So what we will say is, we're going to have you meet with the doctor, and our requirement's going to be that you do what he suggests that you do. Okay. So if he suggests that you take whatever it is, then that's going to be a requirement that the judge and the court's going to hold you to. So ultimately, we're going to say you're going to have to do that to be in our court, but we don't want to just say it right off the bat, and go do this or else. We want to try and have that problem solving approach with them. And honestly, it works good when you say, if you can do it on your own, awesome. This is a little bit of a spin on that. That's exactly what we'll do at the end too. Like when we have people that want to go off their meds after the program, we'll say, I don't blame you. You keep talking to your doctor about it. And if he thinks you can taper off and go down and you can still do all these things, you do it. We'll have them try to problem solve that with that doc while they're in our program. That way, if it slips, they haven't just gone off. And you know what I mean? We can catch it before it gets too far, but it empowers them because they haven't felt like we've just told them no. We felt like we've worked with them and they have a chance to have a say in it. That really works on both ends. But ultimately, yeah, you can't have someone. I did a consultation with the program here a few weeks ago, and they were just we don't have any success because nobody takes their meds. Well, you can't have a program where everybody just runs around unstable. You know what I mean? That's not going to work. So use it, but use it effectively and intentionally, to build that relationship with them as you do it, if that makes sense.
Okay. And we have another question. Can you give an example of the difference between a compliance and a responsivity issue, and then expand on interventions?
Sure. So let me I use the med a little bit, or missing a group, but that's an easy one. So for example, let's say we've got someone that is in phase 2 or even early phase 3 and they miss a group. Okay. If we find out that they missed the group by phase 2 or 3, we're going to expect that they're there, right? So if they just missed, that's going to be a non-compliant at phase 2 or phase 3, right? Because they had a way to do it. If it's phase 1, we want to know what we would do different. So let me back up and make it simpler, because I think if I work through the example, it helps. So let's say we have someone right off the bat that started and doesn't show up to court on Thursday. Okay, this happens all the time. We're probably not going to sanction that person right off the bat. We're going to try to figure out why they missed court, right? So how we will respond to that is by problem solving. So the non-responsive part will be on us. We're going to respond by making sure they have transportation in place. If they say to us, I really did just start taking my meds and I slept through, our treatment people are going to do some kind of a treatment planning with them, whether it's setting an alarm, setting up a backup alarm, you know, they have a roommate, somebody else that helps them. So we want to problem solve so they have that skill. So there's really going to be no sanction to that responsive part at all. It's all going to be treatment adjustment and skill building. If it really is they just missed, then we're going to do a response. We're going to sanction for that. Here's what I will say that I didn't talk much about. We will do contingency plans. Like if we're not sure, we'll do this with them. We'll say, okay, you missed, and we think we know why, but we're not sure. We won't say that to them. We're going to say, here's what we're going to do. We're going to do a contingency plan. So you've earned a day of jail over your head, or 2 days, whatever it is, but we're going to give you a chance to earn your way out of that. So over the next week, if you follow through with all these things, then next week when you come to court, the 2 days gets wiped out. If you don't do those things, we're going to implement the 2 days. And what's great about that is they develop that contingency plan with our treatment folks, and it works on transportation or taking meds, or maybe it's trust. Excuse me. So we may have them call a member of treatment every day just to build a relationship with them so they feel more comfortable reaching out to them. We can put whatever we want in that contingency plan, but we only want 2 or 3 things. And what we want is them to build skills. So ideally next week when they come to court, they've done that. What do? The judge praises them. Everybody praises them. We look at the skills they built and we wipe out the 2 days jail. Does that make sense? So we're building skills all along the way. We're trying to get that. We're trying to get them to respond to treatment. If they just flat don't show up, or even if the expectation is like once they're in phase 3 or 4, if they miss, there's going to be a response from us. If it's because they were, you know, blatantly not there, we might use jail. If we had somebody that did sleep in phase 3 or something, we won't do a, you know, a jail response, but we will do a response with a little bit of a treatment adjustment. Because what's important with these folks, especially this high risk, high need folks, people think the more lenient I am with them, the better. Well, if you're lenient with someone that really has an antisocial attitude and a lot of criminal thinking, what are they going to do to your leniency? They're going to chew you up and spit you out with it, right? So you don't have to be mean. We think firm, fair, and friendly, but you have to still hold them accountable, if that makes sense. Excellent question.
Makes sense to me. Makes sense to me. We've got 2 more minutes. If somebody has another question. I don't see another one in the chat, but he probably could answer one more if somebody's got one. Okay, I'm gonna assume that means no. Thank you so much, Eric. We appreciate it very much. Lots of good feedback in the chat that you about how great this one's been. I know folks are excited to hear you present in May as well, in person. And I know I'm excited about that too. If you do not have your email address in the registration or in the chat, you're not going to get an evaluation or a certificate from us. So make sure that I have your email address or that you have registered so that I can send you an evaluation and you can get a certificate for today. Have a great rest of your afternoon. For those of you that are going to join us in May, we'll see you there. Otherwise, hopefully we'll see you next month at the next Lunch and Learn. Thank you very much. And
thank you so much for having me. Appreciate it.
Bye, everybody.